Welcome to the deep dive. So, I want you to imagine, just for a second, paying thousands of dollars to purposefully burn, puncture, and, well, basically intentionally traumatize your own face.
Yeah, which sounds intense.
Right. And you're doing all this while just hoping that the new scars it leaves behind are, like, slightly more socially acceptable than the ones you walked in with.
It sounds like some sort of medieval punishment, honestly.
It really does. But it is actually the entire foundation of a multi-billion-dollar aesthetics industry. And today, we are bringing you right into the center of it. We've got a really revealing stack of sources for you to go through.
We really do. Some fascinating stuff today.
We have clinical trials on advanced acne scar treatments from the International Journal of Dermatology and Venereology. We've pulled clinic guides on menopausal skin changes. That's from the London Dermatology Center. And we're also looking at brand new safety standards from the British Beauty Council, plus a pretty eye-opening UK government consultation document on licensing these exact procedures.
Yeah, it's a really comprehensive look at an industry that is, frankly, evolving so much faster than the laws attempting to govern it.
Exactly. So our mission here is to unpack the actual science behind these magic wand skin treatments, your lasers, your microneedling devices. We're going to explore the shifting biology that literally drives us to seek these intense interventions out in the first place.
And then, of course, decode the urgent new rules being drafted to tame what is essentially a regulatory Wild West right now.
Because as the technology in these clinics gets more sophisticated, capable of penetrating deeper and altering the skin on a cellular level, the stakes for the consumer just escalate dramatically.
Oh, absolutely. So let's start with the biological catalyst. Before we even talk about the heavy-hitting lasers and needles, we have to look at why people subject themselves to these aggressive treatments.
Right, because looking at the clinical guidance, it almost always points back to massive, often totally invisible hormonal shifts. Specifically, we're talking about the impact of perimenopause and menopause.
Right. Because I think we generally think of skin aging as, a superficial issue, like a buildup of sun damage or some expression lines from smiling or frowning over the years.
But the clinic guides reframe it completely. It's
Yeah.
framed as an internal structural collapse.
Yes, exactly. The superficial signs of aging are really secondary to what is happening at the cellular level. So when estrogen levels drop during perimenopause and menopause, you aren't just losing a reproductive hormone, you are losing a fundamental signaling molecule for skin homeostasis.
Because there are estrogen receptors all over the skin, right?
There's so many of them. They're abundant in the skin, and their primary job, well, one of them, is to maintain the hydrolipid barrier.
And that barrier is like the skin's shield.
Right. It's this complex mixture of sebum, sweat, and lipids that basically traps moisture inside the skin while keeping environmental pathogens out.
And when estrogen plummets, that barrier just effectively dissolves. The dermatology guides actually refer to this as transepidermal water loss, or TEWL.
TUL.
But based on the cellular biology, this isn't just about the skin, drying out because you need to drink a few more glasses of water.
No, not at all. The skin's physical ability to retain hydration is just gone. It loses its structural integrity because estrogen directly stimulates fibroblasts, which are the cells responsible for churning out collagen and elastin.
The actual scaffolding of the face.
Exactly. Those are the protein matrices that give skin its thickness, its mechanical strength. So without continuous estrogen signaling, that fibroblast activity just plummets. The skin literally thins out.
Oh, wow.
Yeah, it becomes translucent, highly fragile, and incredibly reactive. Like a patient might find that a basic lightweight vitamin C serum, something they've used without issue for a decade, suddenly causes intense burning, stinging, contact dermatitis.
Because the chemical is passing straight through a compromised barrier and just hitting unprotected nerve endings.
Exactly.
And compounding this whole structural collapse is a secondary, deeply frustrating biological shift. Because as estrogen drops, the relative ratio of androgen's male hormones increases in the body.
And the reading really highlights how this androgen surplus sends the sebaceous glands into overdrive.
It's like the cruelest double whammy.
It really is. You have skin that is simultaneously thinning, losing its ability to heal, and suddenly being bombarded by an overproduction of thick sebum.
Which triggers those deep, inflammatory cystic hormonal breakouts, usually concentrated around the jawline, chin, and lower face.
Right. And when those cysts eventually subside, The inflammation has already destroyed the underlying tissue, which leaves behind these deep atrophic scars.
And because standard over-the-counter creams or, basic acne washes can't penetrate a collapsed biological structure, patients are basically forced to seek out ways to literally inflict damage on their skin to wake those fibroblasts back up.
Yeah, you can't fix a crumbling foundation with a fresh coat of paint, which is exactly why they arrive in dermatology clinics looking for heavy mechanical interventions. They need technologies that can bypass that compromised barrier and physically force the body into a massive wound-healing cascade.
And that transition into controlled damage is where the American Academy of Dermatology provides a very, very necessary reality check.
They do. It's a tough truth.
It really is, because for anyone looking for a flawless magic wand to erase the hormonal acne scars we just discussed, the AAD explicitly states that lasers cannot magically delete scar tissue.
Right.
They merely replace a jagged, deep scar with a flatter, smoother, lighter one. You are essentially trading one scar for another.
Setting that baseline expectation is so crucial. A scar is formed when the body hastily patches a wound with dense, disorganized type I collagen rather than the neat basket weave pattern of normal skin.
So aesthetic treatments don't erase that tissue?
No, they aggressively break it down so the body can rebuild it slightly better the second time around.
So if the goal is to get the best possible replacement scar, we have to look at how we inflict that controlled damage. And that open-label randomized controlled trial from the International Journal of Dermatology and Venereology is fascinating here.
Oh, it's a great study.
They tested two highly advanced technologies against each other and then tested them in sequence. They looked at microneedling radiofrequency, so MNRF, and fractional CO2 lasers, FCO2.
And from reading the methodology, MNRF seems entirely focused on the deep tissue. You have this robotic stamp of tiny needles penetrating the skin to a precise millimeter depth, and once they hit the dermis, they emit a burst of radiofrequency heat.
The genius of MNRF is its ability to bypass the epidermis, so the surface of the skin entirely.
Exactly. The heat coagulates the tissue deep down where the acne scars are rooted. That triggers those dormant fibroblasts we talked about to flood the area with fresh collagen and elastin, all without burning the top layer of the face.
Whereas fractional CO2 lasers, conversely, work from the top down. The CO2 laser vaporizes microscopic columns of tissue directly on the skin's surface.
And it's called fractional because it doesn't burn off the entire face like those older, intense lasers from the 90s used to do.
Right. It leaves tiny bridges of untouched, healthy skin between the vaporized holes, which helps speed up the healing process.
It's almost like agricultural aerating and topsoil tilling.
Oh, that's a good analogy.
Yeah, the CO2 laser is tilling the harsh, scarred topsoil on the surface, while the radiofrequency microneedling is the deep core aeration, breaking up the compacted earth way down at the root level.
And the clinical data perfectly reflects the value of tackling the scar from those two different vectors. Because when researchers isolated the treatments, the group receiving only the fractional CO2 laser saw a 59.3% improvement in their atrophic scars.
Which is pretty good.
Right. And the group receiving only the microneedling RF saw a 57.2% improvement. Both are statistically significant outcomes for severe scarring.
But the group that received a sequential combination of both treatments, they saw a 70.8% reduction in scar severity.
Wait, a near 71% improvement? That is a massive jump.
It's huge. It perfectly demonstrates clinical synergy. You use the RF needles to rebuild the deep structural volume that was destroyed by the cystic acne, and then you use the CO2 laser to resurface and polish the textural irregularities on the top.
Okay, but wait. If combining them yields almost a 71% improvement, why wouldn't a clinic just blast the patient with both at maximum intensity on day one? Just get it over with. Why spread it out sequentially if we know the combination is the ultimate fix?
Well, because the skin has a finite biological threshold for trauma.
Ah, okay.
If you hit a patient with maximum laser ablation and maximum radiofrequency coagulation at the exact same time, you push the tissue past controlled injury and straight into catastrophic inflammation.
So the whole wound healing cascade just breaks down.
Exactly. Instead of regenerating healthy collagen, the immune system basically panics, which leads to the severe complications highlighted in the clinic guides.
Right, the dark side of controlled injury. Because the London Dermatology Center Guide outlines just how intense the healing phase is, even when things go perfectly. Patients enter what is known as the ugly duckling phase.
Oh, yeah. It's a very real phase.
The skin is bright red, heavily swollen, actively peeling, and it often develops this rough, almost sandpaper-like texture as the deep tissue remodels itself.
And for someone spending thousands of dollars to look better, Looking significantly worse for a month is a huge psychological hurdle. It requires immense patience.
But the real danger lies in the complications that arise when that inflammatory threshold is actually breached. And the most prevalent risk discussed across the sources is PIH, or post-inflammatory hyperpigmentation.
Yes, this is where the treated areas turn into dark brown patches weeks after the procedure. And the sources emphasize that this is a distinctly high risk for patients with medium to darker skin tones. So anyone higher up on the Fitzpatrick skin type scale.
The mechanism behind PIH is actually really fascinating, and it's so crucial to understand. So, melanocytes are the cells that produce melanin, which gives our skin its color.
Right.
But melanin is fundamentally a defense mechanism. It absorbs and scatters ultraviolet radiation to protect our DNA.
So when a high-powered laser heats the skin, the melanocytes interpret that intense thermal energy as a massive radiation attack.
Oh, wow. So they think they're under assault.
Completely.
Uh-huh.
And in darker skin types, these melanocytes are highly active and very robust. So they immediately throw up this melanin shield to protect the tissue, which results in that deep, stubborn hyperpigmentation.
So using an aggressive thermal laser on melanin-rich skin without staging the heat properly isn't just risky. It's biologically triggering the skin's defense system to darken the face.
Exactly. And then there's the mechanical risk of microneedling to consider too, the tram track scarring.
Right, tram track scarring. That sounds awful.
It is. So if a practitioner drags a microneedling device across the skin while the needles are still deployed in the dermis, or if they use a stamping technique with just way too much force on thin menopausal skin.
They literally slice through the tissue rather than puncturing it.
Right. And this leaves permanent parallel micro tears that heal into raised scars that literally look like train tracks.
So if I'm sitting at home 2 weeks after a combination treatment and I'm staring in the mirror at red, swollen, rough skin, how do you actually distinguish between normal, ugly duckling healing and a genuine botched job that needs medical intervention?
The clinical differentiator there is trajectory.
Trajectory.
Right. Normal wound healing is a steady de-escalation. Every day, the redness should be slightly lighter, the swelling slightly lower, and the heat should be dissipating.
Makes sense.
A botched procedure or an opportunistic bacterial infection is characterized by escalation. So increasing pain, spreading erythema or redness, that feels hot to the touch. Any purulent yellow discharge or localized darkening that rapidly gets worse.
Those are signs of the immune system actively losing the battle.
Exactly. And this is why the pre-treatment rules are incredibly strict.
Yeah.
Like the AD mandates that smoking must cease completely at least 2 weeks prior to any of these procedures.
I saw that. I mean, 2 weeks no smoking. Why? Does it just slow down healing?
It's much worse than that. Nicotine is a potent vasoconstrictor. It dramatically narrows the blood vessels, cutting off the microcirculation to the skin entirely.
Oh, wow.
Yeah. So if a laser vaporizes columns of tissue, that tissue requires a massive influx of oxygenated blood and nutrients to rebuild. If you restrict that blood flow through smoking, the skin simply cannot heal. You risk tissue necrosis.
Wait, necrosis, like the skin cells literally die and slow off?
Yes, they just die. And you also absolutely cannot undergo these treatments if you have an active tan or a recent sunburn.
Because many lasers seek out contrast, right?
Exactly. If you have an active tan, your surface melanin is elevated. So a laser designed to pass through the epidermis and heat the dermis will instead violently target that tan surface pigment.
Causing immediate severe surface burns and blistering.
You got it.
So you've got these devices capable of triggering severe hyperpigmentation, permanent tram track scarring, and actual tissue necrosis if a patient just happens to have a tan or a smoking habit. You would logically assume that the individuals holding these lasers are universally subject to intense medical regulation.
You would think.
Ah,
But the UK government consultation document reveals a landscape that is shockingly fragmented.
yeah. The current regulatory framework in the UK is relying on legislation that predates the invention of modern aesthetic technology. Local authorities are largely attempting to police high-street laser clinics using the Local Government Act of 1982.
An act written for traditional tattooing, ear piercing, and acupuncture.
It's wild. It was basically designed to ensure someone sterilizes a needle before piercing an earlobe. It has literally no biological framework for regulating a practitioner using a fractional CO2 laser to vaporize someone's epidermis.
None at all.
Yeah.
And consequently, you have a scenario where highly educated dermatologists and specialized nurses are operating right alongside, frankly, unqualified operators who just purchased a clinical-grade laser online.
And legally, there has been very little distinction between them, which creates a terrifying blind spot for the consumer.
Absolutely. But this is exactly what the government consultation is aiming to dismantle. They are proposing a mandatory national practitioner and premises licensing scheme.
Right, and it's structured around this three-tier traffic light system to categorize every cosmetic procedure by its physiological risk.
Yeah, the traffic light system effectively shifts the industry from a service-based model to a much-needed clinical model. So the green tier encompasses procedures with the lowest risk of deep tissue complication.
This includes things like superficial chemical peels, basic microneedling that doesn't penetrate the deep dermis, and LED light therapies.
Right. And under the new proposal, any licensed practitioner who proves they meet rigorous, standardized hygiene and training protocols can perform these.
Because it acknowledges that these treatments, while they definitely require skill, don't carry the risk of permanent structural damage if a minor error occurs.
Exactly. But then we step into the amber tier, which covers medium-risk procedures. This includes the radiofrequency microneedling we discussed, medium-depth peels, high-intensity focused ultrasound, and dermal fillers or botulinum toxin.
And the critical pivot in the amber tier is the requirement for clinical oversight. A non-healthcare professional, like a beauty therapist, could potentially perform these, but only under the direct supervision and responsibility of a named, regulated healthcare professional, like a doctor, nurse prescriber, or dentist.
And that oversight is so vital, because if a practitioner accidentally injects dermal filler into a facial artery, which can cause instant tissue death or blindness, they need immediate access to prescription-only reversal agents.
Right, they need hyaluronidase, the enzyme that instantly dissolves hyaluronic acid filler or emergency antibiotics.
And a standard beauty therapist cannot legally stock or prescribe those emergency medications.
So the oversight ensures that a medical safety net is immediately present when the biological stakes are raised.
Exactly. And then the proposal moves to the red tier, which covers high-risk, surgical-level interventions.
Which includes the deep fractional CO2 lasers, thread lifts where barbed sutures are physically pulled through the facial fat pads, and any fillers injected into intimate areas.
And the red tier legally walls off these procedures entirely. The proposal dictates they can only be performed by regulated healthcare professionals. And crucially, they must be conducted in premises registered with the Care Quality Commission, or CQC.
Which means a standard high-street beauty salon with a treatment bed in the back room would be legally barred from firing a CO2 laser at a client's face, regardless of the operator's individual certification.
Yes, it forces high-risk procedures back into clinical environments equipped for infection control and medical emergencies.
It protects the consumer from opportunistic practitioners, but honestly, it also protects the legitimate, highly trained aesthetic professionals who are constantly undercut by unregulated operators offering cut-rate, dangerous treatments.
And we are seeing the industry step up while they wait for Parliament to pass the laws, too.
Yeah.
We see proactive frameworks like the Sharp Standards Guide, launched by the British Association of Beauty Therapy and Cosmetology, BABTEC, alongside Dermatologica.
Right. They're pushing clinics to adopt clinical-grade hygiene, rigorous sharps disposal, and comprehensive informed consent right now without waiting for the law.
And we've already seen precedent for strict legal boundaries in this space. The Botulinum Toxin and Cosmetic Fillers Act of 2021 made it a criminal offense to administer those treatments to anyone under 18 in England.
And the fact that primary legislation was required to stop practitioners from injecting neurotoxins into teenagers really speaks volumes about the historical lack of self-regulation in the sector.
It really does. It was long overdue.
So just synthesizing this entire stack of sources, we've traced the whole arc of aesthetic intervention today. We started by looking at the unavoidable biological catalysts, like how the loss of estrogen physically dismantles our skin's hydrolipid barrier and structural collagen, driving us to seek out aggressive solutions in the first place.
And then we break down the mechanics of those solutions, looking at that incredible 71% clinical synergy of combining deep tissue radiofrequency coagulation with surface CO2 laser resurfacing, physically forcing the body to regenerate.
But we also analyzed the severe risks of pushing the tissue too far. from post-inflammatory hyperpigmentation caused by the skin's melanin defense shield to the permanent tram track scarring of improper technique.
And finally, we mapped out the imminent regulatory shift. That traffic light system designed to finally classify these powerful technologies as medical interventions rather than just standard beauty treatments.
It is such a fascinating look at the collision of aging, technology, and law. But, as these procedures become highly regulated, scientifically optimized, and theoretically perfectly safe under the CQC and new licensing laws, it really forces us to look at the social implications.
Absolutely.
Like if the risk of a botched job drops to near zero and inflicting controlled injury on our faces becomes as standard and routine as, say, going to the dentist for a cleaning.
Well, the barrier to entry just becomes entirely psychological and financial.
Right. And if erasing the structural damage of time becomes a mathematically precise, perfectly safe routine, do we risk creating a society where natural aging is no longer seen as an inevitable biological process,
Yeah.
where it's viewed instead as a failure of basic personal hygiene?
That is a terrifying thought, but very possible.
If you have the perfectly safe option to renovate your face, what will it mean socially if you simply choose to opt out? Definitely something for you to ponder the next time you're scrutinizing a new line in the mirror. Thanks for joining us on this deep dive.